Okay, welcome to RadPath lecture number 2, Getting Through Tumor Board. So we got some great feedback from the first lecture, which is a lot of fun. This presentation is going to be potentially overwhelming, but I'm going to try to keep it really simple, fun, and you can go back to this anytime you want to through the ACR building blocks where you will find this full presentation. This is, and as well, check out the Anki deck for the RadPath flashcards. So this is based on a RSNA presentation from a couple years ago about how to get through Tumor Board. Tumor Board can be very overwhelming if you let it be, or you can make it be fun, and that's how I try to approach it. So here's our table of contents, the contributors to this presentation. And let's just start with Tumor Board. I was at Tumor Board today. I go every week for a GYN Tumor Board, and we have a great team. Surgeons are there, radiation oncology, and the pathologists. And then me as the radiologist, am responsible for showing the images. For me, that's a lot of fun and pretty straightforward. Here's a PET CT, FDG avid lesion. We'll have often biopsied it, in this case under ultrasound, and you end up with the pathology. Now, when I do the biopsies, one of my favorite things is to look under the microscope with the pathologist, see if we have an adequate specimen, try to come up with our differential. I really enjoy working with the pathologist, sort of tell them what we're thinking, what we're seeing, if I have a good specimen or not a good specimen. And that will actually be the topic for our next RadPath lecture, how to get an adequate specimen. But it really involves some collaboration with the pathologist to get that good sample and ultimately to best help the patient. So I like this slide. When you are at Tumor Board, you might be tempted to tune out the pathology, but that's actually doing the patient a disservice. And if there's a couple of tricks, things we can remember from pathology, it will really make this part of Tumor Board more interesting, and I think make you a better radiologist. So this review is not a condensed version of 4-year pathology residency. Just like we cannot condense radiology into 35 slides, we cannot condense pathology into 35 slides. I'm going to try to give you some highlights, some tricks, some tips. Again, the goal is to have a basic foundation so that you can get through Tumor Board and have a better idea what's going on. I do not pretend to be a pathologist. I enjoy it. I like looking at slides and learning every day. A great thing is that radiology and pathology share a lot of similarities. The way we talk about things, the suffixes, prefixes, again, you guys can come back, look at this slide, see how many of these terms you know. Similar thing here. Here we have, this is one thing I like to look for, pleomorphism. Just the cells all look different to me. That's something I can identify. That's never a good thing. And that goes with cellularity in the nucleus. If you can identify mitoses, irregular cells, irregular nuclei, that is not a good thing. So that will go into cellularity, mitotic rate, and again, actions in the nucleus. Again, I'm going to be going through these. You can go back at your own leisure. And this really comes down to pathologic grading, high grade, low grade. This was something that was a little bit confusing to me starting at the Tumor Boards. What do they actually mean by that? And this is an example of a low grade papillary urothelial carcinoma, whereas this is a high grade. Here we see the mitoses, pleomorphic cells, all looking different. And this is a key concept, so I really want to highlight this, that radiology is rarely helpful in determining grade. Pathology is, that's the gold standard for determining the grade of the tumor, but what radiology can help is where to direct the biopsy. And that's why it's so important when we're doing these image-guided biopsies to have pathology there, trying to get the viable part of the tumor. So when they look under the microscope, they're like, oh yeah, that's viable cells. and not necrosis. We'll see that coming up later. We want to try to give the pathologist as good a sample as possible. Radiologists and pathologists both talk about architecture, and this is pretty neat. I like this part of the presentation where we go back and forth. This is the patient. This is showing a lobular carcinoma on the MR, and then the pathology showing the Indian file-like organization. Again, go back on your own time. Don't get lost in the details, but I want you to get a sense of how radiologists and pathologists talk. Same thing for cell shape and size. I like this slide. Here we have 3 different types of tumors, and then the corresponding pathology with the different shapes: spindle, epithelioid, and round. Again, that is a key concept for the pathologist when they're looking at their specimen to make that determination. So that is a key point. The cytoplasm. So we talked about the nuclei and the cytoplasm. Again, here's a nice example going between the pathologic lesion and what it looks like under the microscope, and we'll see different cytoplasm. Eosinophilic here, this was from the normal renal transplant. The basophilic, more purpley, and then the amphiphilic. Necrosis, we said this is a big deal for when we're getting our samples. We want to try to get viable tissue and not the necrotic tissue, but sometimes despite best effort, all you get is a lot of necrosis. Again, this was a case of a GBM, peripherally enhancing, and under the microscope, just lots of necrosis. This is something that we talk about in radiology and pathology, how the mass interfaces with the normal tissue. Is it well circumscribed or is it infiltrative? And again, some nice examples here. Got a nice core around it. Here, the capsule is broken, infiltrative. Again, can go back and forth. And I really encourage you guys to go back and look at the full presentation. Other descriptors. This is a great case of a dermoid which had keratin on it. And again, the dermoids make some of the best rad path cases. So those are always some of the students' favorite. So staining. So this is the bread and butter for our pathology colleagues. We all remember the H&E stain. And I'm going to skip that case. You guys can look at that on your own. But the process of staining is something that I encourage everyone to do. If you haven't done so already, spend some time with a pathologist where they will get the specimen, oftentimes put it in paraffin, and then they get the fancy meat slicer. This is in the frozen room, and we'll put it on the slide and then apply the different stains. And immunochemistry is a huge technology that has really expanded our knowledge, understanding these diseases, leading to all these different types of stains. And this really blew my mind the first time I saw it. When a pathologist gets a specimen, at least at our institution, they get a sheet like this, and they have to decide which stain are they going to do. They're not going to do all of them. They're going to have an idea of what they're looking at, and they will make their decision based on the clinical information. The great thing is they can always go back. They save these specimens, and sometimes at Tumor Board, we'll often, the radiation doctor will often say, well, hey, did you get the estrogen stain on this? I'm curious if it's going to be ER positive. And they're like, no, we didn't get that. They can go back and order that stain. So that has been, that was a new thing to me. I thought they were one and done, but they can actually go back and do additional stains. So let's talk about pathology, how pathologists think about tumors. There are 5 categories. So again, this is another very important topic that I want everyone to understand, that pathologists categorize tumors into carcinomas, sarcomas, neural crest, which will include the melanocytes, lymphoma, and leukemia. Sounds easy. But as you guys know, it's very complicated, and that's why it's a 4-year residency. We have the tumor, we want to stain it, and realize it can be stained at either the membranous level, the nuclear level, or the cytoplasmic level. That's the other key concept I want us to understand. When we're doing these stains, we have 3 targets. Again, the membrane, the nucleus, or the cytoplasmic proteins. And we can get lost in all the detail of all these fancy stains, or we can just try to have this playbook and a general understanding of what's going on. And that's the approach I try to take. So again, for carcinomas, we have our membranous, nuclear, and cytoplasmic stains. And this is a nice example of a patient with a liver lesion. We're doing the stain, and this is for ER, estrogen, and progesterone. And we go back and we see those are nuclear stains. So that's how I like to approach these cases when I'm thinking about them. What are they trying to stain, and why are they doing it? This can get a little bit complicated, but when the pathologist showed me this, it made a lot of sense that just like we have algorithms for lesions based on MR sequences, is it T1 bright, T2 dark, T2 dark, T1 bright, is it enhancing or not? And we come up with our own differentials. The pathologist will do the same thing with their stains and can really narrow down the differential, and that helps them decide what the ultimate diagnosis is. Like this complicated case, which I will let you guys go through on your own, couple of different stains, but pathology saved the day. Tissue was the issue and led to the correct diagnosis of a carcinosarcoma. Lymphoma, again, we can break these down into membranous stains, nuclear stains, and cytoplasmic stains. And lymphomas can get very complicated, and that's why there are pathologists who do special fellowships in lymphoma leukemia. This was our original case. This was the lymphoma, our FDG avid axillary node. We got a good biopsy. And this is a focus case. I will let you guys do this on your own. But again, tissue was the issue, and pathology made the diagnosis. We'll talk a little bit about melanoma, the great imitator, remembering we have stains at the membranous level, the nuclear level, and the cytoplasmic level. So these are the different stains you might hear about at Tumor Board. Again, just remember, is it membranous, nuclear, or cytoplasmic? And realize there's special stains for the melanoma. This was a great case showing the PET CT, the MRI, and then the gross specimen. And then under the microscope, putting it all together, confirming the diagnosis. Some nice examples of pleomorphism, mitoses in action. So this is our cheat sheet. So if you want to print this out, take a picture, this is what I bring to Tumor Board. Remembering that we break the tumors into carcinomas, lymphomas, melanomas. And we can stain these tumors at the membranous, nuclear, and cytoplasmic level. So in summary, tissue is the issue. Tumor Board can be intimidating, especially the pathology side, but if you can break it down into the different tumor types, break it down into the different stains, bring that cheat sheet, and I'm telling you, you'll see those stains presented at Tumor Board, and it will start to make more sense. And realize that pathology and radiology have a lot of similarities. They're complementary fields. And one of the best things about Tumor Board is how we all work together to get the best diagnosis for the patient. Again, I encourage everyone to check out the full presentation at the ACR Building Blocks site. Thank you.